So I presented the primary readout of the ENRICH study at ASH in San Diego at the end of 2024. So the ENRICH study was a randomized phase 3 study comparing rituximab plus ibrutinib to immunochemotherapy in first-line treatment of mantle cell lymphoma for those patients who are over 60 years old and not considered fit for autologous stem cell transplant. So the data up until now really suggested that the standard of care for first-line treatment of mantle cell lymphoma in this population is immunochemotherapy in most cases, with either R-bendamustine or R-CHOP most commonly. There are some phase 2 studies looking at the role of BTK inhibitors in the first-line treatment of this population, but up until now, there'd never been a randomized study comparing ibrutinib or any BTK inhibitor with immunochemotherapy. The study design was such that investigators were allowed to choose their choice of immunochemotherapy prior to randomization. So investigators made a pre-randomization choice for each patient of either R-CHOP or R-bendamustine, and patients were then randomized to either the choice of immunochemotherapy or to R-ibrutinib. If patients were randomized to ibrutinib, they received rituximab as per the rituximab program that they would have had if they'd had the chemotherapy. So in other words, 4 weekly for bendamustine choice and 3 weekly for R-CHOP choice. All patients went on to receive 2 years of maintenance rituximab in both arms, and the patients in the ibrutinib arm had ongoing ibrutinib treatment up until disease progression or until unacceptable toxicity. So the study was open at 66 centres in the UK and in the Nordic countries, so in Sweden, Denmark, Norway, and Finland. And we recruited 397 patients to the study. The majority of patients, 73%, had a pre-randomization choice of R-bendamustine, and about just over a quarter had the pre-randomization choice of R-CHOP. In terms of patient characteristics, the groups were well matched. The median age in this study was 74, and we had a good distribution of high-risk patients with about 50% of patients having a high-risk MIPI score, and we had about 8% of patients having a P53 mutation. And, well, in fact, it was 20% of those who were tested, but we didn't test everyone. At the time of the readout of the study, when the study read out in June 2024, we had a median follow-up of 48 months. The primary endpoint of the study was progression-free survival, and the test was a test of superiority of IR over immunochemotherapy. And at the time of study readout, the study was positive, so there was a PFS advantage of ibrutinib-rituximab over R-chemotherapy with a hazard ratio of 0.67, and this was highly statistically significant with a p-value of 0.03. We pre-specified in the statistical analysis plan that we would do a test of interaction, in other words, to see if the R-CHOP and R-bendamustine chemotherapy choices were making a difference to the outcome of the study. And we found that this was highly statistically significant. In other words, the patients who had a pre-randomization choice of R-CHOP were doing significantly differently to the patients who had a pre-randomization choice of R-bendamustine. So what we then did was we went on to analyze the progression-free survival of R-ibrutinib versus R-chemotherapy individually depending on the treatment choice. And what we found was that the benefit of IR over immunochemotherapy was largely due to the R-CHOP arm doing significantly worse than the R-ibrutinib arm. And actually, the patients who had a pre-randomization choice of R-bendamustine did fairly similarly. So in other words, the PFS for those with R-bendamustine was very similar to those with IR. And in fact, the patients who had who were randomized to R-CHOP in the pre-randomization choice of R-CHOP actually did much worse than we'd previously expected. When we looked at the actual events that were happening in the study, in other words, the events that were leading to PFS, we found that in the R-CHOP arm, this is almost all due to an increase in progression events. So it genuinely seemed that R-CHOP is much worse than IR at controlling disease and preventing progression. The PFS curves for IR versus R-bendamustine were roughly equivalent. Thinking about toxicity, we found that patients who were randomized to immunochemotherapy had significantly increased rates of hematological toxicity, particularly in patients who were randomized to R-CHOP. But this was counterbalanced, if you like, by an increased rate of cardiac toxicity in those patients who had IR. And when we looked at subgroup analysis, we found that the benefit of ibrutinib over immunochemotherapy was particularly marked in those patients with less proliferative disease. And in fact, patients who had more proliferative disease, particularly those with blastoid disease, actually didn't do quite so well with ibrutinib-rituximab. And actually, probably these patients probably would need better treatment choices for these patients with blastoid disease. So I don't think ibrutinib-rituximab is the answer for those patients. So the ENRICH study, I think, demonstrates that ibrutinib-rituximab is a really good treatment option for some patients with first-line treatment of mantle cell lymphoma, particularly those patients with less proliferative disease. And certainly I think that if your centre is currently using R-chop, then ibrutinib-rituximab is superior to R-chop. And I think one of the things that the ENRICH study is going to really change, I think, is a reduction in the amount of R-chop that's used, because R-chop is still a standard of care for mantle cell lymphoma in a lot of the world. Whereas I think the ENRICH study has shown that R-chop probably is maybe not as good as we expected it to be leading up to the study. Certainly, if you've got the choice between BTK inhibitor and R-chop, then I would suggest that ibrutinib-rituximab is superior.